Accogliamo ora la dottoressa Giorgia Ramantani, medico dirigente EEG Epilessia, neuropediatria dell'ospedale pediatrico di Zurigo, con il tema SLC 6A1, inquadramento clinico, fenotipo ed evoluzione della malattia.
So I will speak in English. Thank you very much for the invitation, and I hope that I have managed to include in my talk what you actually need in your very nice meeting here. I have to say that, well, first of all, I have to introduce myself. I am new to this round. I am a pediatric neurologist and epileptologist, and I am the head of the epilepsy service in Zurich. My own interest is mostly in refractory epilepsies of all kinds, genetic and also structural. And we have a lot of patients with rare genetic epilepsies in Zurich, about 500 and more, but we did not have a case that I could bring to this meeting. So I don't directly treat any patient with this specific disease. So I am actually also a little bit of a newcomer, but very interested in this topic. So in yes. So in my talk, it's a little bit of everything, but mostly the clinical phenotype, what I actually see in my everyday clinical practice. For me, also the correlation of the etiology of this disease was quite new, but now my talk is coming after many talks which went into great depth in the specifics of the biology of this syndrome. But again, this is one brief overview, so if you decide to go for the coffee break and skip my talk, this is the most important part. One part of the story is that we know exactly what is happening in this rare epilepsy, which is in itself quite rare, and it's also a source of hope and opportunity. We know that it's about GABA, it's about this G80 transporter, and we, I mean, you probably know the pathophysiology better than me, how it works, and what this transporter is doing in the GABA pathway. And this affects the brain and its development, and this is why most of these patients end up in the epilepsy service or in pediatric neurology clinics, because most of these children will have a developmental delay, they will have seizures and epilepsy. Seizures and epilepsy, in many cases, they appear as the very first symptom. And then we have behavioral issues and autism traits, which are also very frequent, and this is one of the major genes also for autism and not only for rare epilepsy. And then we have movement disorders. So these cases are keeping lots of specialists within pediatric neurology occupied with different issues. And then we have the etc., which is sleep disorders, but also gastrointestinal disorders, and a lot more. So again, this has been perfectly covered by the previous speakers. We know that GABA is the main inhibitory neurotransmitter in the brain. This is quite major. We know that G81 is the main transporter. And we know that this G81, it is helping to clean up and return the GABA which has been delivered, which is in the transsynaptic space. And if the G80 function is reduced, then all the balance is gone, and it's not just a reduction, it's just an out of balance situation which occurs. We also know how this works through haploinsufficiency, and this is something that this disease shares with a more frequent rare epilepsy, which is Dravet syndrome. So we know that there is one gene copy which is not functioning properly, but this itself, it's enough, because the remaining copy doesn't produce enough of this normal GAT1, and this ends up in a disbalance that this reduced amount suffices to disturb brain function. And another important part of the story, at least to me a realization, is that 82% in this largest study from 6 years back are de novo variants. So we don't know exactly about these cases before birth. Then again, there is a parallel from basic research which helps to understand the disease in humans, in children. And this is a nice diagram, again from this study with the 116 patients, which was published 6 years ago. And this is a trajectory over age, over days. And then this is the signal intensity of different parts of this complex story. And what we can see is that there is a very quick upward trend in the first days of life, and then there is a stabilization. And this practically explains also why this is a pediatric disorder, why it is very important to treat, to recognize and treat very early, and why all of these treatments should be targeting in the first days of life. Although the gene is expressed in the CNS, in the central nervous system, mainly in adults. So it's about, GABA is about inhibition, and we know that in the brain the inhibition is maturing, mainly in adolescence, after the adolescence has been concluded, which is sort of in contrast to the fact that we have this very quick upwards trajectory through the embryonic development. So it starts very, very early, and in very early life we have huge changes, but this is something that is it's a process continuing through adolescence and into adult life. Let me move. And we also know, you also know better than me, that there is a variable expression, variable symptoms, variable pieces of the puzzle which are appearing in different patients. And of course, this situation is related to the fact that this is a genetic disease, and there are differences in the variants and differences in what is actually occurring in all of these cases. This is only covering, unfortunately, it's not, you can probably not read everything, but this is about 13 cases which were very well analyzed in this publication which came out last year. And you will see that everybody had some neurological issues. Then most of the cases had cognitive, behavioral, less cases had any kind of motor issues. And then the communication, for example, gastrointestinal, were definitely more rare, and sleep disorders or musculoskeletal disorders were reported in just a handful of patients. So it is it's a group, it's a puzzle consisting of many pieces, but different patients will have different pieces of this puzzle, and also in different prominence and across their life. Of course, this situation translated to a very difficult story for the parents, because we have a disease which is challenging. It is a rare epilepsy, but it's not only about seizures, because the children have developmental delay, they have speech and language and therefore communication issues. Then the seizures start, which are a huge throwback for development. But we also have the behavioral issues and the autism, which is usually diagnosed later in life. We have the effect of the medication. We are using anti-seizure medication to stop the seizures, to keep them under control, but these medications in themselves, they also have some side effects. Then some of these children, some of these families also report sleep disorders, which are of course also very important because the child cannot sleep and also the parents cannot sleep to take care of the child through their daily life. Some of these children, they have movement disorders which become of course more prominent as they grow older and as they are supposed to walk and participate in daily life, which is all about motor balance and use of all motor functions. And of course this translates into a loss of quality of life for the families, which can be also described as a nightmare. The most comprehensive paper publication on the different symptoms, which are the different pieces of the puzzle in this disorder, is the publication from Goodspeed et al. From 2020. And I will go through with you through all of these figures in this publication. It's the largest one to date. It's also very important because this kind of large publications where we know what children had at a specific time point are of course very important for all of the children, all of the cases which are diagnosed nowadays. And also regarding the goals we are going to set in any kind of treatment. So across this group of 116 patients, we can see that the epilepsy, seizures and epilepsy was the most frequent symptom. 91% of the cases had an epilepsy. And the second most frequent was 82% developmental delay. And developmental delay can be very variable, but most of these cases, they actually have a mild or moderate developmental delay. And the third part is autism, autistic traits. This is not autism exactly, it's autistic traits. It's some behavioral issues which may or may not be a true autism. And then we have the varia, we have ataxia, movement disorder, we have attention deficit, ADHD, we have aggression, difficult behavior, and we have again movement disorders and 3 cases of schizophrenia, which is of course something really to worry about. It's just 3 cases, but still it is 3 cases, and this means that these cases reached adulthood and were diagnosed with this disease. While most of these children are very, very young. So what is actually missing in this huge group is the trajectory. What happened when, and how many cases were how old, and which symptoms came at which time point. What is missing is actually a natural history of all of these cases, and of course many more cases because only some of the mutations are covered in this large overview. So I'm an epileptologist, so of course I need to focus on epilepsy syndromes. And the first described cases were described of LCLC 6A1 were described in correlation with the Dose syndrome. It's one of these old syndromes of the pediatric age with atonic and myoclonic seizures. The seizures come out of the blue, and children have myoclonic jerks, and also such seizures where they lose their posture and they have drops. This was the first description in 2015, and this sort of started all of this boom behind this disease. And still, most patients are actually diagnosed with this Dose syndrome, which is nowadays called epilepsy with myoclonic atonic seizures. It has a different, longer name, but it's exactly the same thing. 24% of the cases have this early onset epilepsy. So this is also something for clinicians to think about, and also for geneticists, that if we have the presentation of a Dose syndrome, which in itself is quite rare, we should think of this rare genetic epilepsy. Then 23% have a genetic generalized epilepsy. And this is again 1/4. And why is it important? Because in many genetic generalized epilepsies, we don't really have so many genes which are coding this presentation, so this is probably one of the important genes. And then we have the varia. If you look through all of these abbreviations, we have even childhood absence epilepsy, we have temporal lobe epilepsy, focal epilepsy, non-acquired, non-structural. We have Lennox-Gastaut syndrome. We have a little bit of everything, or some cases with no seizures. What about the seizure semiology? Seizures, again in this group, 116 patients. 72% were absences or atypical absences, which is a very frequent seizure type. I mean, one of the most frequent pediatric epilepsy syndromes is a childhood absence epilepsy. But this is of course not childhood absence epilepsy. These are different absences. They are atypical absences. And this is a realization that we reach very early while treating the disease. And then children have atonic and myoclonic seizures. And this is why they fit very well into the spectrum of the Dozier syndrome, where children have exactly these seizure types. And this is not, the rate is not so high, it's probably around 15%, but some children have generalized tonic-clonic seizures. And although the generalized tonic-clonic seizures are not so frequent, they are very dangerous because of sudden unexpected death in epilepsy. And this is why this is also a population where we need to be careful with supervising the children, maybe even with some wearable devices. I mean, the wearable devices which are available nowadays, they are not working properly, and this is the truth. I mean, they have lots of false negatives, lots of false positives, but at least it is some kind of observation, some way to keep track of what is happening with the children, because they also have these seizures, which can be very dangerous. I mean, also, of course, the myoclonic and the atonic and tonic seizures are also dangerous because children can hurt themselves. They can drop. But generalized tonic-clonic seizures are a lot more dangerous than all of the other seizure types. And then we have the eyelid myoclonia, which sort of fits into the spectrum of absences and generalized seizures overall. And we have some focal seizures, like in all kinds of genetic epilepsies. We have the generalized and the focal seizure semiology, and the focal seizure semiology is more rare, but it may occur. And this does not mean that this is a focal epilepsy, it's just a focal seizure type. And some of the children, again, a very low percentage, luckily, they may have a non-convulsive status epilepticus, which is another important part of the puzzle, because in some cases parents observe a change in behavior. They observe a change in interaction, a change in maybe movement, maybe an increasing rate of myoclonic jerks. And then it is important for the treating physician to get a video EEG and see if this is a non-convulsive status epilepticus, because of course this needs a different treatment, and we should find out about it as soon as possible and treat it as soon as possible, of course in the hope that we are changing the trajectory of the disease. So all across rare epilepsies, genetic epilepsies, maybe across all epilepsies, there is an interplay between the seizures and epilepsy and the developmental delay. And we can follow it also in this rare epilepsy. So maybe from the back of the room, it's not very clear with the two different colors, but the yellow color designates the before seizure onset, and the red color is after seizures have started. And here you can see the different categories of development. So you can see the normal, learning disability, and then you have the mild developmental, delay and severe developmental delay. First of all, you can see that most of the cases are within the spectrum of mild and moderate developmental delay. But something is changing. So 60% of the cases had developmental delay before seizure onset, and then it's over 80% of cases who have developmental delay after seizure onset. So the seizures, of course, are aggravating the clinical picture, and they are adding to the developmental delay in these cases. And of course, it is important to stop seizures and to treat seizures as well as possible. Overall, in treating epilepsies, regardless of refractory or non-refractory, genetic or structural, we are speaking about treating early. We need to treat early because these epilepsies usually start very early in life. So children we need to treat are usually very young. And then there is this, of course, hope, which is grounded in many cases, that the earlier we do something, the better the results are going to be in the end of whatever treatment we apply. However, this has to be taken with a bit of salt because we know that we have different conditions across childhood. This is a very simple diagram, which I like to draw also for my patients, where you can see the development and the age. And then the black line is the normal development, the normal child, the child who does not have seizures, does not have any underlying disease, healthy. And then you can see the case is the blue, the epileptic encephalopathy. This is a normal child who has a seizure because of a benign tumor. The tumor is removed, and then he has quite a good chance to return back to the trajectory of the normal child. But this does not apply to the majority of the patients we treat. Most of the patients we treat are either on the purple line or on the yellow line. So they already had a hard start in life. You can see that there is a distance between the normal child and the child with the developmental epileptic encephalopathy. And then seizures appear, and then there is again another deterioration of this developmental trajectory. And this is sort of defining the scope of our expectations. So you must have heard these three different terms many times, but let's focus on the developmental and epileptic encephalopathy. And skip this best case scenario of everything will be good once we stop the seizures, because this doesn't really apply to this kind of genetic epilepsies. Let's go to the developmental and epileptic encephalopathies. Children have a cognitive development and behavioral impairment which is independent to the epilepsy onset. We can see that many of these of the children, they had a developmental delay before the onset of the first seizures, 60%. And then epilepsy has a high seizure frequency and lots of epileptic discharges in the EEG. The EEG that we do is pathologic. Okay. If we manage to stop seizures, then the neurocognition and the neurobehavior will remain impaired. So by stopping the seizures, we will not be able to return the developmental trajectory back to normal, but we will return it back to where it started from, which is a little bit behind the normal child. But there will be some improvement. So stopping seizures definitely makes sense in every context, but it will not offer a full normalization. And this is this also defines the let's say the expectations also regarding all of the anti-seizure agents. We use lots of anti-seizure medication. It may work more or less, it may stop seizures more or less, but it will not cure the disease. So is there hope for this disease? Of course there is hope for everyone. We are working on it. This is the bottom line. So it is one of the key genes in epilepsy and autism. So it is rare, but not so rare. There are many cases, there are many families, many people working in this direction. And it has, we know how it works. So it has a known biological basis, both in vitro and in vivo. There are even common anti-seizure medications like the valproic acid, the vigabatrin, which have existed for many years, which are used in treating many epilepsies, and they can modulate the GABA pathway. So we have something in our hands, and there are even opportunities, for example, in in gene therapy, because it is a small gene. So this is a little bit of luck in a difficult situation. And this is a plausible candidate for a viral mediated gene therapy, and research is progressing in very big steps. So, what about this gene replacement therapy? Most of the studies I found from the last year are about gene replacement therapy. So obviously it is a very big chapter, and something that many families are looking out for. This means that this applies to diseases where we have a partial or full loss of function of the protein, which is coded by the gene of the affected gene. But if something is missing, maybe it can be replaced and treat this disease. And these gene replacement strategies, they involve this acronym of AVV, the adeno-associated viruses, which need to deliver at specific parts of the brain in the brain, so they have to go through the brain-blood barrier, and this also needs to happen at specific time points during development, because of the first slide I showed you, where you see this this very fast trajectory in the first days of life. And actually, this has already been applied to the SMA type 1, and it works. Maybe not perfectly, but it works. And this was a completely hopeless disease some years back, not even a decade back. And it has shown promise in Dravet syndrome, which is very similar with this haploinsufficiency to what we are talking here about. And I will not go in depth because it was not the topic of my talk, but I found this diagram very interesting. Of course, it's about mice. It's not about the children that I treat, clearly. But I found it very interesting because of different parts of the story. I found it interesting because of the intrathecal administration. Of course, it's invasive. The intravenous did not really work. It was interesting to me because of the time point. Because of the neonatal injection, it will not work. But first of all, we will not really know if the child has the disease on day one. A very important part of the graph is the mortality. Look at the very high mortality rate at the beginning, and then the first time point, the P5, where it works, and it works much better than later. So P5 works better than P28, and these are just days between these time points. So the earlier, the better it is bound to work, but too early did not work either. Of course, this is not mice and not men and not little children, and we are very far from, not very far, hopefully not very far, I take it back, hopefully very close to a solution, but the solution will require to address a lot of issues. And I will close my talk with a simple diagram. What should families know about this disease? We need an early holistic insight. This is not just about seizures, it's also about neurodevelopment, it's a lot about behavior and also autism, it's also about movement disorders, about sleep, it's a huge box of things, it's not just one label. Then these children, they need a holistic care and support. Obviously from the pediatric neurologist, but at the same time from many specialists, because they have a lot of different issues. And they also need support from people who work in research, because research is working on future therapies and on new therapies, and this is a very fast forward moving field, and I hope that there will be a lot more to talk about in terms of new treatments, but also in terms of natural history studies, not 10 years down the road, but maybe even next year. Thank you so much for inviting me.